Our guest speaker today is Dijana Dragicevich. Dijana qualified from the University of Canterbury, New Zealand in 1997. Her first job was working with people post-stroke in a rehab unit in Hawke's Bay. Since then, Dijana has worked in the UK in 2 large teaching hospitals, in rehab hospitals, and in people's homes, specialising in post-stroke communication and swallowing disorders. She moved to Sydney in 2011. Now Dijana works part-time at Royal North Shore Hospital, where she is completing a PhD in swallowing disorders following stroke. Her other part-time job is working with NDIS participants at home, so she gets to see people at all stages of their journey. Dijana does guest lecturing at universities and teaches support workers how best to communicate with people with communication problems. Outside of work, Dijana enjoys bringing up 2 teenagers and walking DY Beach.
Thank you, everyone. It's really nice to see so many of you today, and also to see that so many of you have got such a personal experience of either having aphasia yourself or caring for someone with aphasia, which is just fantastic. So Rachel's already done this, but I'd like to also acknowledge the traditional custodians, the Gayamagal and the Garigal people in their country on which I reside today. By these words, I show my respect to all Aboriginal people. I acknowledge elders past, present and emerging, and the spirits and ancestors of the clan that lived in this area. So, a lot of you already know what this is, but aphasia is defined as a language disorder that makes it difficult for people to express themselves or understand language. And it's really specific in that it is a language disorder. It's not a general cognitive disorder. It doesn't affect intelligence or the ability to think or have thoughts. And I think that that's really important because people with aphasia still have the same thoughts. They still have the same need or desire to communicate. But what's really frustrating is they have difficulty getting access to that language to be able to express those thoughts. So it can be very frustrating. Unfortunately, aphasia affects all aspects of language. So unlike a speech disorder, so the other really common communication disorder that we see after a stroke is called dysarthria. That just affects the speech. It doesn't affect the writing or reading. Aphasia, as being a language disorder, affects all aspects of language. So that means it affects reading, it affects writing, it affects obviously the talking, and it affects listening or understanding the words that people are saying. And it can be different for everybody. So some people will have more difficulties in the writing or understanding, and other people will have more difficulties in the use of language or talking and reading. So everybody sort of affects everybody uniquely in different ways. Some of the things that we see in aphasia is that people have a lot shorter sentences or incomplete sentences. So what that means is there may be just single words where there would have been a sentence. So for example, someone might say drink instead of saying I would like to have a drink. Or they might say go boy dinner later, which may have come out as go and get the little boy across the road and tell him that we're going to have dinner a bit later. So the sentences are much more compact, with sometimes a lot of those little words missing. So those little and or the words missing. And often that the meaning can still be the same, even though lots of those little words are missing. Sometimes the sentences that people with aphasia can use don't make sense at all. So sometimes the words that come out are what we call jargon, or made up words, or words that are unrecognizable. Sometimes the words can be substituted for another word. So instead of saying table, they might say chair. And so the meaning is a little bit related. So we call that a semantic paraphasia. It's a similar word error. Or sometimes it could be, it sounds the same. So the word might be slable instead of table. And that's a phonemic error. So the word is almost the right word, but just a few sounds are not quite right. Sometimes the words are unrecognizable. Like I said before, we call that jargon or neologisms. A neologism just means a new word. The most common symptom really is that they have difficulty finding words. So this word finding difficulty is the key impairment that we see in aphasia. So, you know, they know exactly what they want to say. That word is up there in the head and they can see what they're talking about. Sometimes they can even use the hands to make a gesture or point to it, but that word is just not wanting to come out. On the other end of the spectrum is the understanding problems. So not understanding what people are saying. And sometimes that can be limited to the amount or the complexity of information. So long as you keep the information short and simple, that's easily understood. But once you get into long, complex sentences or start talking about things that are not related to the here and now, or if it's in a big group with lots of people talking at the same time, too much language going on and much more difficult to understand. And that's the same thing with reading. So sometimes reading just more simple words that are on their own is no problem, but put words into larger contexts or into a novel, and that language becomes more difficult to decipher. And sometimes, just like saying words and sentences that don't make sense, writing words and sentences that don't make sense can also be a feature. So aphasia is a language disorder, and it occurs from damage to the brain. It's been in the news recently because Bruce Willis has been diagnosed with aphasia. I'm sure all of you have seen that. The speech pathology community thinks that it might be primary progressive aphasia because it's talking about how he's been getting worse. And in aphasia post-stroke, the worst day is the day of the stroke, and people get better over time. Whereas primary progressive aphasia, unfortunately, the aphasia gets worse over time. But we thank Bruce Willis for bringing his condition to everybody's attention, because we need to highlight aphasia a little bit more and increase people or the general public's understanding of aphasia, because there isn't good understanding of aphasia in the community. But the areas of the brain that are responsible for language are generally on the left-hand side of the brain for most people. So this is the dominant part of the brain for most people. We say that people who are right-handed will have their left part of their brain dominant, the left side of the brain. There is a very small percentage of left-handed people who will have the right part of their brain as a dominant part, or the language center. And then there's this bit in purple down the back. That's the posterior part of the brain, or more posterior part of the brain. It's not quite at the back. And then this bit in green is more anterior part of the brain. So we know that if you have your stroke in a more anterior part of the brain, you'll have what we call Broca's type aphasia, or a non-fluent aphasia, sometimes it's referred to. And that produces generally good understanding, but more difficulties getting the words out. So less words, but better understanding. Whereas damage to the more posterior part of the brain, that induces more words to come out, but less understanding of those words. So you may have heard that we talk about lots of different types of aphasia. Aphasia isn't just one term that encompasses everybody. It depends on whereabouts in the brain the damage has been done. So we have, you might have heard some of these terms: a Broca's type aphasia, a Wernicke aphasia, transcortical aphasia, conduction aphasia, mixed aphasia, global aphasia. So how do we find out who's got what type of aphasia? Well, the speech pathologist will do some different types of testing, and there are different features, I guess, or skills that go with the different types of aphasia. So firstly, the first thing that we find out is the production of speech, is it fluent or is it non-fluent? So are there lots of words that come out or not many words that come out? So that's yes or no. And then is understanding good? Yes or no. And then does the person with aphasia, are they able to repeat? Yes or no. And then we can decide on what type of aphasia that person has. And this is important. You may think, oh, does that really matter? Is it important? For a speech pathologist, it is important because it tells us about what kind of treatment might work the best and what sort of prognosis there will be, or how recovery will look over the next days, weeks, months, and years. So I want to just show you a couple of examples, but have a listen to this lovely lady and maybe have a think about, if you can think about whether you think that she's fluent, whether she speaks easily or she doesn't speak easily, and whether you think that she understands or she doesn't understand. So this goes for about 3 minutes.
I'm sorry? Tell me about your daughter.
Me?
Yeah, your daughter.
I don't know. She poggers a foy and she sends in a pay, a poor popular poi, and she lends in overlend elephant loss, and she mends things as a serve. And she's away a little on the period.
She goes away sometimes.
Periods, yes, she turns off. She gets a real one whenever she's out, and she lives off a lot, and she gets a lot in Detroit.
Do you live with your daughter?
I'm sorry.
Do you live with your daughter?
Yes, I do. And she does. She doesn't pay her appointment of her and a boy in the pouring. She rehearings a lot. She a toy, and she stays on the never not employed.
Okay. Does she is she out a lot? Is she?
She does.
Okay. And do you have any grandchildren?
No, she doesn't.
And let's see. And were you a hairdresser?
Well, yes, I heard of Terry before to Ireland, of course, and heard her saw to baby, and she had a son, a small bailey, and she was a ware labourer, and she was lucky wind. Oh, she made a good sore boy, and she had a regular toy, almost double.
Oh, okay.
So she could.
I'm talking about your hair. Were you a hairdresser?
Oh, yes, she does.
You?
Yep, she does.
Oh, okay.
She leaves little splabber and tip off. I get a make for a day of course for her, and she gets a little bit light of hovered eye, and she laying on and gets a bit lot off, and size it off, and she gets some quite new.
Well, I'm afraid I'm not following very much.
Yes, she does. She lays olive regular Floyd log, and she leg her up popular oil all the time, and She wears a polo, a polo. Which is nice. That looks very nice.
My hair.
It's very nice. Yes,
Thank
it does.
you. I've
Very
just had it
nice.
cut recently.
Oh, does it?
I don't really like it.
Don't you?
No. Bit short here.
Yeah, no, it's very handy. Show me. Oh,
What did you think of this lady? Do you think she was fluent? Did the words come easily, or was she non-fluent?
She was very fluent, but we couldn't understand everything that she was saying.
Yeah.
Not at all.
You could easily,
No.
you could easily confuse that lady as suffering from dementia, I would have
My
thought.
mum.
And that's such a great point, because she walked into the hospital and people looked at her and saw that she was old and just put that together and said, oh, she's just a confused old lady.
Yeah.
And so that's exactly right. She wasn't confused. She's had a stroke. Because her comprehension was poor, she thought that what she was saying was making complete sense. And then I kept it on for that 3 minutes, because right at the end you could see that actually she initiated. She looked at my hair and she said, oh, but your nose is nice.
Yeah.
And I said, oh, my hair. And we got that communication going, because there was something. She was a hairdresser in her younger years. And so once we talked about something that was relevant to her, we were able to connect and make a really good conversation part there. So yeah, excellent. She was a fluent aphasia with poor comprehension, and we would call that a Wernicke's aphasia. All right, and I've got another one I want to show you here.
So, you going? What happened to bring you into hospital?
I encountered a big
Were you at home?
yes, and the day we I have never really
Was it last night?
yes, no, the night before. And
And were you, was it in the evening while you were sleeping, or was it while you were sitting down watching telly?
my daughter, she we grade something restaurant, and she
Was she around at your house?
no, but she agreed. She and she never heard me speak like this before.
Oh, was that on the phone then?
Yes,
You rang here?
yes.
Okay, so you get the idea there. Does anyone want to tell me what they think of this lady?
Broker's aphasia.
That's exactly right. She has a Broca's aphasia.
All the time.
Yes, that's right. It's very, very frustrating. You can see the frustration.
I know.
And so what did you think about her understanding?
Sad.
Yes.
Yeah, she's got good understanding, hasn't she? She knew what I was talking about. And when I got things wrong, she corrected me.
Yes.
So, yeah. So when we talk about how aphasia affects people, a lot of people get very focused on the impairment. So what can't they do? So those sorts of things are things like, I can't find the words, I produce the wrong words, I can't understand reading, I can't understand what people are saying. And that's the impairment. But there are also things that aphasia stops people from being able to do in their day-to-day life. So those are things like, I can't enjoy reading a novel anymore because it's difficult to get that information on the paper into my head. When we go out to dinner, I can't choose from the menu because I can't understand the words, especially because a lot of the words in a menu are it could be French words. They're not everyday words. Participating in a group discussion where lots of people are talking at once and it goes really quickly from one person to the next person. Understanding and following a show on TV and understanding and following a recipe. So even though that's not impairments, those are the things that have that functional limitation on what people can do. And then that means that their participation in life might be restricted. So that means that they might choose not to go out for dinner because it's too difficult, or they might not be able to go back to work because it would take too long to do some things. And so they have real impact. Aphasia can have a real impact on somebody's life. And they're often very misunderstood by other people. So I don't know if any of you who've got aphasia can add to this, but often if someone sees that you've got difficulty talking and you're with your carer or your husband or whatever, they stop talking to you and just talk to the other person. Yeah, so they get ignored sometimes, or they get considered, unintelligent or unable to think for themselves. And yeah, real difficulties expressing those needs and wants and those feelings, those emotions, how you're feeling, those are very heavy. Our emotions are very heavily described by the words that we use. So difficult to tell someone how you're feeling without using words. I mean, there's a certain amount we can do with our face, but some of those subtle emotions, they really are difficult to express by facial expression alone. Now, a lot of people ask me, well, what about prognosis? I had speech pathology for 3 months, and then they said there's no more improvement to be made, so they stopped seeing me. And I want to tell you that that's not true. There are a certain amount of improvements that can occur in the impairment. So those are the things we were talking about before, like the word finding difficulties, the difficulties maybe understanding certain grammatical differences in writing, or maybe spelling. Those sorts of improvements, they can improve to a certain extent, but they will be limited. That's just the impairment though. With those other things that we talked about, so the activities, so being able to choose menus in a restaurant, being able to communicate feelings, all those things that are more of a functional task, they can improve forever, because you don't always need to have to do those verbally. You can find lots of other ways to be able to do those things. And the same thing with participation. So there's lots of improvements that can be made, that can be made for people with aphasia in that functional and quality of life participation side of things. I've got a little example I can tell you about in a minute. What can speech pathology do? So speech pathologists should assess all of those 3 areas. So not just the impairments, what you can't do. That's important, More important in the early days, less so important in the later weeks and years. But those activity limitations. So what are the things that you want to be able to do that you can't do now? Those are the activity limitations that need assessing, and the participation restrictions. So those things that you want to be able to get access to, but you can't. So, you know, do you want to be able to participate in group activities, or want to be able to get a volunteer job doing something? Those sorts of things should be assessed by the speech pathologist, and then treatment improves all of those things. So treatment can improve the impairments. That's a focus on those earlier weeks and months. And then those strategies to compensate for the difficulties in activities. So maybe strategies of understanding written information a bit better, so that you can choose things from a menu, if we're sticking with that theme. And increasing access to community or social or work environments. So what I'm trying to say here is it's not always about the impairment. It can also be about functional ability to do tasks, and also wider about getting back into the community and accessing those things that you want to access. So here's my little example, and it is made up, but hopefully it illustrates how you can look at the impairment, the activity, and the participation. So this is about a 62-year-old woman who had a stroke that caused aphasia, and she was a volunteer working in the Red Cross clothing shop, and she looked after her grandchild one day a week. And so she looked after her grandchild one day a week. So she was able to understand, but her talking was limited to 1 or 2 words at a time. So in those 3 different areas, speech pathology can help Patricia to work on the impairment, so they can focus on maybe selecting some keywords that she would use in the Red Cross shop to help her get back to that environment, and maybe some keywords that she might want to work on with her grandchild when she's with her grandchild. So that might be around some food items, or some preschool activities, or some things that are around their immediate environment. So keywords that she might want to work on, and those things are working on the impairment. And then to work on the activity, speech pathology might establish some sort of communication aid, which would have some of those key words in it. So when she couldn't use them verbally, she could get the communication aid and use that. And then the participation. So that is about how we can improve the environment to help Patricia function at her best in her environment. So that would involve going to the daycare and going to the Red Cross and educating them about how best they can communicate with her, and how they can help her function to her best in that environment. So how can you help someone with aphasia? So I reckon a lot of you know all of these things already, but we really want to keep language clear and simple, because sometimes the complexity of language can be too difficult. So keep things nice and clear, short and simple. Speak slowly, but not overly slowly, and not really loud, because they're not deaf. It's not affecting their hearing. And then you can emphasize the keywords. So I don't know if you picked up on how I was doing that in some of those videos, but you might want to emphasize key words. So you just sort of emphasize the word you really want to understand. You give the person extra time to speak and formulate thoughts. So people with aphasia, it does take them longer to take in what you want to say, what you're saying, sorry, and then be able to formulate what they want to say. Using the short phrases and sentences, I mentioned that. The background noise and distractions can be quite a competing thing for people with aphasia. Is the more noise and distractions that are going on, the more difficult it is to understand sometimes, or focus on the language. And then using all forms of communication to reinforce what you're saying is really important too. So I might say, do you want a drink? Or should we go now? So all the ways that we communicate with our face, are you sure? We can communicate a lot more by just using the words. yeah, and drawing or using the communication aids as well. You can help someone express themselves by not interrupting. So sometimes, the second lady that we saw on the video, so she had a lot of trouble getting the words out. And sometimes I knew what she wanted to say, but it's knowing when to interrupt. And then you can always say, can I help? Can I guess the word you're trying to say? And they will either tell you, no, don't do that, or they will go, yes, help me out. And different people want different things. If somebody has an alternative communication system, encourage them to use it. So, oh, do you have a communication book? Do you want a piece of paper? So offer different ways to communicate if they have those available. Sometimes asking those yes and no questions just makes things a little bit easier. So are you talking about going to see so-and-so? Yes, that's what I'm talking about. And then you've got the context that helps with the understanding of what you're talking about and what they're talking about. Don't ask too many questions too quickly, because that can become overwhelming and then they don't know which question they're supposed to be answering. And look as well as you listen. So you see how they're communicating. So if they're looking really frustrated or sad or like you're not understanding what they're saying, pick up on that and say, I can see that you're looking really frustrated, or it looks like you're telling me about something that's made you upset, because they're telling you with their face as well as with their words. And then remember that they will know when you don't understand. So don't pretend to understand. Just say, I'm really sorry, I'm not understanding at the moment. Can we try again, or shall we come back to that in a little bit? And what you can do to help. So many people don't know what aphasia is. You guys are the best people to help spread the word. And if you have got aphasia, I think it's really important that we get people with aphasia included in research and developments in stroke. So often people with aphasia are excluded from stroke research because it's thought of that they can't understand what the research is all about. And that's not always true. They may need extra help to understand some of the complexities of the research, but it doesn't mean that they should be excluded. And if you're looking for things to donate to, there's excellent aphasia programs, the Aphasia Excellence Centre for Research Excellence, which is based in Melbourne and Brisbane, I think, and the Australian Aphasia Association, which are great to promote aphasia and what it's all about. So that's what I've got to talk with you today. I'd really love to hear your experiences and understand if you've got any questions or want to share with me anything.
We just wanted to emphasise the point that was made, and I'm glad you're really glad to hear you say it about how improvement is not just in that first 3 months. I mean, this has been an overriding message we've been saying for years. Part of the Maitland Aphasia communication group, and we're seeing members in there that who would be lucky to have said 1 or 2 words. A lot of that was also about confidence in social settings. Yep. In our group, ensures that people are given the time and also the confidence. Sometimes they can actually say a lot more than they can say, but they're not confident because they think in themselves they might be ridiculed or they might not be listened to or whatever it is. So our group has, I think, helped a lot of people gain that confidence. And we talk about the social setting afterwards. I think that's just as important as the speech exercises that we do during the group, because we encourage our people to actually go up and order their lunch. And because we tend to go to the same restaurants time after time, the people that are behind the counter get used to the people ordering.
And you feel a lot more confident in those types of environments, don't you? Where you've got that support and you've got the other people around you, and you've got the opportunity to practice your skills. So I think communication groups like that or aphasia groups like that are just so fantastic.
Amazing.
Working on that participation and that activity side of the aphasia. So it's really, really brilliant. It's so good that they're available.
Dijana, I might jump in for a question if you don't mind. But what are the current, I guess, aphasia therapies that you're finding are being successful? I know that there's like constraint-induced aphasia therapy and different methods like that. Are there any that you're personally finding to be really effective?
Well, I think it's difficult to say a broad statement about the different types of treatments, really, because everybody responds differently to different types of treatments. It's individualized. What we know is that recently there was a big international study about intensity and of aphasia therapy, and whether intensity should happen in the acute setting or whether we should wait until the rehab setting. What they found was that it wasn't as useful in the acute setting to provide that intensive therapy.
No way.
It was much better to focus that on at the rehab phase or when you're at home. And that makes sense to me as well.
A lot better.
So I think that in those early days and weeks, what's most important is education and educating people on how best to communicate with people with aphasia, talking with family members and helping them to take the burden of communication whilst things are still recovering. And then in the rehab phase, so really after those sort of 12 weeks, that what they've found is that's the good time to really get in there with the intense treatment. So
horrible.
You know, and then there's lots of different types. So for people that have got more of a Wernicke's type aphasia or more of a fluent type aphasia, there's some treatment called I can't remember the name of it now, but they read something and then they summarize the information without using lots of extra words that don't make sense. There's script therapy that's been shown to do that to have good outcomes. So practicing saying a script, and that might be as simple as introducing who you are and what you like to do. That's sort of a script, and rehearsing that many times so that there's certain things that you can produce. So that works quite well. There's a really one that's been around since I graduated 25 years ago now, called PACE therapy, which is promoting aphasics communication effectiveness. And that works on encouraging people with aphasia to communicate in any way possible. It doesn't have to be speech. And that's really encouraging people that to communicate. It doesn't have to be speech. That the message is get it out any way you can. Communication is communication. It doesn't matter if it's speech or writing or facial expression or gesture. And yeah, so there are lots of different types, and they're all effective. I've seen them all be effective for different people at different times. We're really lucky in Australia. We've got some of the best researchers in the world in aphasia. So, you know, we're up there leading the way as well.
Excellent. It sounds like repetition is key, as a lot of other allied health professionals would say.
Repetition and opportunity to practice. That Maitland group encourages them to have that opportunity to practice.
I had a question. I heard you say about the left brain picking up, right-handed and the left brain picking it up. So what happens if you're left-handed?
Yes, that's a good question.
Well,
so
I was wondering what happens to those people.
Well, even if you're left-handed, 25% of people that are left-handers will still have their left part of their brain as their dominant part of their brain. It's a very small percentage of left-handed people that have the right side of their brain as the dominant part. So really it's down to assessment. If you're left-handed, it's something that we would keep in mind. But most people that are left-handed will still have the language
on their left.
Yeah.
Drag was on the left side, so she has Broca's aphasia, but the ability to sing wasn't affected. Yeah. So she could sing and in sentence, you know, knew all the words to songs and could sing the songs when she couldn't speak in sentences, because it's a different part of the brain as well.
That's right. So the singing or all the sort of arts and crafty type things are all stored on the right-hand side of the brain. And there's a great therapy called melodic intonation therapy, which is kind of a little bit out of favor at the moment because there are other things that are more popular. But the theory behind that is that it uses singing to facilitate production of words, and then you gradually stop the singing so that it becomes more speech-like. So you might start by going, "Hi, how are you?" And then over time, you still produce that "Hello, how are you?" but it's more or less singing.
At one of our recent conferences, we had a few allied health professionals talking about working together in the multidisciplinary team. How do you in your practices work with other people, and do you find it difficult, I guess, and like how do you work together to get the best outcomes?
That's a great question, and I love that question because I'm a very big MDT advocate. In the acute setting, it's really important. I work probably the closest with an occupational therapist because you know, one of the things we're hoping to get for the patient with aphasia or the patient who's had a stroke is getting home as quickly as possible. And so the OT wants to know about their cognition and how they're going to be in the kitchen and make sure that things are safe. And I want to be able to make sure that they can call for help if they need to, or they're able to communicate with their loved ones, and their loved ones know how to get the best out of their communication as well. So we often do joint sessions together where we'll look at how cognition and communication can overlap, and often write discharge reports together too. And then in the community, so I work with NDIS clients as well at the other end of the spectrum. So they've been through the acute, they've been through the stroke unit, they've been through rehab, and now they're at home. And we at Bloom Healthcare, which is the company I work for, we're a multidisciplinary team. So a lot of NDIS companies, they don't, you know, they just do speech pathology, or they'll just do physio, or they'll just do, and it's much, much more difficult to communicate together or have shared goals and that sort of thing. So I'm really fortunate that I work in a company where we have everybody already together. And so, you know, the OT will go out and do their assessment, and I'll go and do my assessment. Sometimes we'll do it together, but then we'll all get together and talk about it and talk about, okay, well, this is my goal. How can you incorporate that goal with what you're doing? So that when when the OT is going to see the client, they're thinking about, well, Dijana's got the goals of making sure that, I don't know, that the person's able to follow the recipe. So when we go and do the kitchen work together, the OT, we're going to get the recipe and make sure that it's in that format that Dijana said was the best to be able to follow. And, you know, you're working on goals together. Or similarly with things like memory and using a diary, scheduling, and all those sorts of things, they're very joint OT speech pathology goals. So I think in the world of NDIS, it can be difficult because everything is time, and time is money. And that's what's so nice about having an MDT, because you're already employed by the same company. It's not hard to try and get in touch with somebody else. You're already there, but it is a challenge when you've got people in different companies to get them to talk together and to make those joint goals and joint sessions, joint work. I do some telehealth appointments too. And so, you know, if the occupational therapist or the psychologist is working with the client and I need to see them, they'll go and be the person with them at the time so that I can have do the telehealth, but also have a person there with them. So there are lots of ways that we work together to get the best outcome for the client. I think the other thing as well is assistance. So there's a lot more that we can do with speech pathology assistance now to really get a lot of practice in, working with the support workers as well. So teaching support workers how to communicate really well, getting them to do lots of practice, reinforcing lots of strategies that we've taught. So that's all MDT working too.
Yeah, excellent. And one other thing I did want to ask as well is, how does your, I guess, initial assessment and then treatment differ in the acute setting to, say, someone who's had a stroke 12 years ago or 20 years ago?
You're full of such great questions today, Rachel. That's a great question, because in the acute setting, I'm often the first allied health person to see a client because of their swallowing. We have a guideline. The Stroke Foundation sets up the guidelines, as you know, and the really important one is that everybody who has a stroke must have their swallowing assessed within 4 hours of getting to the hospital. So that means that the speech pathologist is often there. Sometimes I'm there before the doctor. So the nurse will see them, they'll do the swallowing screen, and I'm there. So oftentimes, you know, I'm seeing people and they're really understandably upset, they're grieving, they're in shock. It's an awful situation. They often don't remember that as well, because they're in such shock. They often don't remember that I've been there. And so that first day is very different from how they're going to be the next day and how they're going to be the next day, because the brain recovers quite quickly. Most people with an acute stroke will improve rapidly within the first 3 weeks, and then it slows down, but still improvement over the next few months and so on. So my assessment in that period is much more fluid and informal. There's no point doing a standardized assessment that takes an hour and a half on day 1 or 2 or 3 or even 7, because the next day or the next week, they're completely different. So what's the point of wasting their time, wasting your time, and it being completely not useful? So the assessment is more about getting a good idea of what the difficulties are, and starting treatment early. So starting helping people to communicate with their family, starting to maybe do some practice of gesturing so that they can get their message across, or you know, doing some communication together, like looking at photos and talking about photos. So just encouraging sort of communication in those really early days. And then down the track, when people have had aphasia for some time, they would have had lots of assessment over that period. So for me, in my current role in the NDIS, it's more looking at not so much the impairment, although that is a factor, but we can get that information from other reports. It's more about the activities. So how does the aphasia impact on the ability to carry out everyday tasks? So how does it impact on being able to communicate at church, or being able to follow a recipe? I know I'm being repetitive here, or you know, ordering a menu at a cafe. So those are sort of the limitations. So that's more what I want to know. Can they read the medication on a bottle when they're going to take it, so that they know how many pills to take? It's that sort of thing that's really functional, more than the impairment. And then also, you know, how is the aphasia affecting quality of life, and how can I make that quality of life better by helping with the communication? So it's a very different approach in that in the community setting down the track. It's more focused on living well with the aphasia and finding ways to compensate for the difficulties, and finding new ways of being successful in the activities that you want to do.
Can we please, joining me in a round of applause for Dijana for an excellent presentation.
Thank you. It's so nice to meet you both.